Jeremy, for the invitation to speak about malaria today. Good afternoon, everyone. I'm just going to stop my video now and continue with the talk. So today we're going to be talking about hot topics in malaria, and like Jeremy said, some really interesting developments over the past few years. So the beginning of summer generally marks the start of the malaria season in South Africa. This is due to the higher temperatures and the increased rainfall in the malaria transmission areas. And the malaria endemic regions in our country are beginning to see increases in the number of malaria cases as expected, marking the start of the malaria season. Following confirmation from the National Department of Health's Malaria Directorate, the NICD issued this alert approximately 2 weeks ago, signaling the start of the malaria season for this year. Also last week, there was a commemoration of the Southern African Development Community, or SADC, Malaria Week, which usually takes place between the 6th and 10th of November. And this is dedicated to creating awareness and educating the public about malaria, as well as other health-related issues such as HIV, AIDS, and TB in the region. So in addition to South Africa, SADC member states affected by malaria include neighboring countries like Angola, Botswana, Mozambique, Namibia, Zambia, and Zimbabwe. And malaria is the leading cause of morbidity and mortality in the SADC region, causing an estimated 50,000 deaths in 2022. So given all of this, it is indeed an opportune time to recap, talk about the epidemiology and parasitology of malaria, but also to highlight some important emerging issues, including the implications thereof for our clinical and laboratory practice. So let's start with some important facts about malaria. And here are some latest global malaria statistics as reported by the World Health Organization from 2022 World Malaria Report. And this report reports on statistics for 2021. So malaria is endemic throughout most of the tropics, with 50% of the world's population, that's now about 4 billion people, at risk across 84 endemic countries. And malaria alone accounts for approximately 8% of global disease burden. The WHO reported 247 million malaria cases in 2021, with the African region shouldering the heaviest malaria burden. An estimated 234 million cases in Africa and 593,000 deaths in 2021. And this equates to 95% of cases and 96% of all deaths. So it's interesting to note that just 4 countries, Nigeria, the Democratic Republic of the Congo, Uganda, and Mozambique, accounted for almost half of all of these cases. When we're looking at deaths, 619,000 malaria deaths occurred globally, with the devastating statistic that 77% of these deaths were in children under the age of 5. So if we look at the trends for the past 3 years, we see that malaria cases continued to rise between 2020 and 2021, although at a much slower rate than from the previous 2019 to 2020. Cases stood at an estimated 247 million in 2021, compared to 245 million in 2020 and 232 million in 2019. However, there are no further increase in malaria deaths in 2021. In 2019, we know before the COVID-19 pandemic struck, there were an estimated 568,000 deaths worldwide, and this estimate rose to 625,000 in the first year of the pandemic in 2020, with increase in cases and deaths being due to interruption of services due to the coronavirus pandemic, as well as revised method of computing the malaria burden. Deaths then fell to 619,000 in 2021. So progress has been made over the past 20 years with regards to malaria mortality. The percentage of total malaria deaths in children aged under 5 years reduced from 87% in 2000 to 76% in 2015. Since then, however, there has been no change in this trend. So malaria is one of the big three, including TB and HIV/AIDS. So to contextualize the malaria figures, every year there are 10 million cases of TB globally, with 1.5 million people who die from TB each year, making it the world's top infectious killer. In comparison, in 2022, 1.3 million people acquired HIV, with 630,000 people having died from HIV-related causes. So it's important to look at the estimated incidence per thousand population. And if we look at this global malaria dashboard, which reflects 2021 data, let's focus on the African continent. And you can see that malaria transmission in South Africa is situated on the southern edge of the malaria transmission belt in sub-Saharan Africa. And in our more northern African countries, there's constant year-round infection. And this is termed stable transmission. And most malaria infections in long-term resident adults here are asymptomatic as they become semi-immune following repeated exposures. In these areas, symptomatic disease occurs mostly in children under the age of 5 who have not yet developed immunity. In areas where transmission is low, highly seasonal or focal, full protective immunity is not acquired and symptomatic disease occurs at all ages. So malaria behaves like an epidemic disease in some areas, particularly those with seasonal, unstable malaria, such as Southern Africa, including in South Africa. So outbreaks of epidemics can occur when there are changes in environmental, economic, or social conditions, such as heavy rains following drought, or migrations of refugees or workers from a non-malarious region to an area of high transmission. Breakdown in malaria control and prevention services can intensify outbreak conditions, and these situations usually result in considerable morbidity and mortality amongst all age groups. So what this means for us, according to this map, is that the estimated malaria cases per thousand population at risk in South Africa is approximately 1 per thousand population. Malaria eradication, that is the global elimination of human disease, is still the global vision of the World Health Organization. It is an ambitious goal, which if attained, though, will save millions of lives. However, they do admit that successful eradication efforts will require tools that are not currently available. And this speaks to the critical importance of accelerated research and development. However, malaria control and elimination, as per these definitions, are more attainable, with control being defined as reduction of disease incidence and prevalence to levels that do not pose a threat to public health or that are acceptable to a community, and elimination being defined as reduction of incidence and transmission to zero in humans in a defined geographic area. So this is attainable as evidenced by several countries who have eliminated malaria and been successfully certified malaria-free, including Algeria and Mauritius from the WHO African region. But in all instances, to control malaria, you need a surveillance system that can detect, respond to, and report malaria cases and infections promptly, and this is essential. In terms of the South African context in recent years, there has been significant progress in efforts to eliminate malaria. We are part of the E2025 initiative, being identified as having the capacity to eliminate malaria by 2025. COVID-19 pandemic challenges underlay a 30% increase in cases in E2025 countries in 2021 compared to the previous year. However, despite this, 2/3 of reporting countries continued their progress towards elimination, showing case reductions, including South Africa, case reductions by 33.7%. And the WHO also hailed South Africa for bucking this grim trend in the face of COVID. It was one of the few malaria endemic countries in Africa that did not see a major upsurge in malaria cases caused by COVID-related disruptions. However, it was not all good news, because for the second time in a decade, South Africa is set to miss its malaria elimination target. The country had committed to ending malaria by 2018. Obviously, that did not happen. And in 2019, the goal was set again to end malaria by 2023. So despite implementing a number of interventions which have reduced the country's malaria burden, there has been failure to halt the transmission of malaria within our borders. And there are numerous and complex reasons for this, but COVID did play a role. Resources were diverted to deal with the COVID pandemic. With restrictions, there were staff absences in healthcare facilities. Due to fear, patients were not presenting or delaying visits to healthcare facilities. And when they did present, symptoms of malaria and COVID were often confused, or cases were missed, malaria cases were missed. Vector control and surveillance activities were severely compromised in these 2 years. And there was also a reduction in test and treat activities of mobile malaria border surveillance units. And these units play a major role in reducing malaria in border communities and in highly mobile migrant populations. So here we have the distribution of risk of malaria transmission in South Africa, the map which was updated in December 2018. Local malaria transmission occurs mainly in the low altitude areas, that's below 1,000 meters above sea level, in Limpopo, Mpumalanga, and KwaZulu-Natal provinces, but most especially in areas bordering Zimbabwe and Mozambique. Malaria transmission occurs mostly in the rainy season between September and May, and Plasmodium falciparum accounts for a majority of malaria cases and is the predominant species associated with severe and fatal illness. So despite limited transmission in our country, malaria remains one of priority diseases for the National Department of Health. Transmission is heterogeneous across South Africa's endemic provinces, and progress towards elimination has been variable. As we see here in the Limpopo province, the Vembe and the Mopani districts experience the highest burden of disease. In Mpumalanga, transmission is highest in the Bushbuckridge and Komazi municipalities of Ishlandzeni district, and that's Mpumalanga's only endemic district. As compared to the other endemic provinces, KwaZulu-Natal reports the lowest burden of malaria cases. So what this all means and equates to is that approximately 6 million people residing in these areas are at risk for malaria in South Africa. So surveillance that malaria is a notifiable medical condition. It's a Category 1 NMC, which requires healthcare practitioners to report cases within 24 hours of diagnosing a case. You can go to the NICD website. These are the case definitions that are categorized into suspected, probable, and confirmed, as seen here. And I think this is just to highlight, to remind people it is a legal requirement. And the importance of notification is to enable disease tracking in endemic provinces, to do active surveillance, and to investigate reasons for cases in non-endemic areas. This surveillance data informs information like these malarial seasonal trends seen here, reported by season between September of the prior year to May of the subsequent year. And here we see data for 2008 to April 2023. So these are malaria cases and deaths for the country over the past 15 years. And what you can see of note is that malaria case numbers and deaths rose significantly in 2017. And this was following heavy rainfall and other logistic and operational challenges within the Limpopo province predominantly. But with subsequent interventions, we see the impact with case and death reduction in the following years. So during 2020 and 2021, we see lower numbers, and this was as a result of reduced cross-border movements because of COVID regulations, as well as proactive actions by the provincial malaria control programs. However, more recently, the country's malaria case numbers started rising, as you can see, in early 2022, following the lifting of these travel restrictions. If we look more closely at the data for the season 2022-2023, you can see that there are approximately 7,000 cases and 70 malaria attributable deaths. Now, cases are classified as local or imported. So a local case is a malaria case within a malaria receptive area where there is local transmission and there's no recent history of travel to another malaria endemic area. An imported case is a malaria case whose source of infection can be traced to an area outside of South Africa where the patient has recently traveled. So here you can see that majority of cases reported are imported cases. There are cases that are unknown, either because the information is still to come or there's no information. The 3 endemic provinces, that is Limpopo, Mpumalanga, and KZN, obviously report local transmission, with Limpopo having the highest burden of disease. All the other provinces see imported cases. Gauteng province, being the economic and travel hub that it is, reports a high proportion of these imported cases. And during malaria season, the information always makes it to the news and social media. And then just last week, News 24 released this headlines of the fact that more than 7,000 cases have been reported, with nearly 70,000 deaths in South Africa to date. So just a word about Odyssean malaria, and this is not the same as imported malaria. Odyssean malaria, or minibus or taxi or airport malaria, refers to malaria transmitted by an infected mosquito which is translocated. That is, the patient has no travel history to a malarious area, and the other more uncommon routes of transmission, such as blood transfusion, injection, or needle stick injury, have been excluded. So as you can see tabulated here, the NICD has been involved in many outbreak investigations of Odyssean malaria cases over the years. There have been 163 cases between 1996 to 2022. And I think the important takeaway message from this is that we will see Odyssean malaria cases in South Africa, given the volume of road, rail, and air traffic travel from malaria risk areas. But it's rare, it's sporadic, and because it's often an unexpected diagnosis is missed or delayed, with resulting high case fatality rates of approximately 10 times higher than the national fatality rate for malaria. So it's really important to bear malaria as a differential diagnosis in mind, especially in a patient with unexplained fever and thrombocytopenia, even in the absence of travel. So just to recap on the parasite itself that causes malaria, and we are talking about the Plasmodium species that cause human malaria. So there are 5. Plasmodium falciparum causes the largest burden of disease globally, followed by P. vivax. And P. falciparum predominates in sub-Saharan Africa, on the Indian subcontinent, in Eastern Asia, Oceania, New Guinea, Haiti, and the Dominican Republic. P. vivax is much more common in the Americas and the Western Pacific. P. malaria is uncommon. It's found in most endemic areas, especially in sub-Saharan Africa. Plasmodium ovale is less common, but is unusual outside of Africa and comprises more or less than 1% of isolates. P. knowlesi is similar morphologically to P. malariae, and it has been identified by molecular methods in patients in Malaysia, the Philippines, Thailand, and Myanmar. And in more recent years has been causing more infections and more deaths than seen previously. There are other species that have been detected, such as P. simium. It's a malaria species resembling P. vivax that occurs in primates, but has been isolated from human cases in Brazil. So what would a parasitology talk be without a life cycle? But they are important to remind ourselves about the vector, the parasite, and the disease. So the malaria parasite is transmitted by the bite of a female Anopheles species mosquito, which commonly occurs between dusk and dawn. And only female mosquitoes bite humans or animals to obtain protein needed for producing eggs. There are other rare mechanisms for malaria transmission, and these are congenitally acquired disease, blood transfusion, sharing of contaminated needles, and organ transplantation. So a word on the vector. The most effective mosquito vectors of malaria are those such as Anopheles gambiae in Africa, which are long-lived. They occur in high densities in tropical climates. They breed readily. They rest and bite within dwellings and bite humans in preference to other animals. So when we look at the life cycle, which is involving two hosts, the mosquito and the human, starting at 1, during a blood meal, a malaria-infected female Anopheles mosquito will inoculate sporozoites into the human host. And these sporozoites enter the circulation and infect liver cells where they mature into tissue schizonts. Here, replication occurs via schizogony, which is binary fission, a form of binary fission, producing tens of thousands of merozoites. So tissue schizonts rupture and release these merozoites into the bloodstream. Just of note, in P. vivax and P. ovale, a dormant stage, or hypnozoites, can persist in the liver and cause relapses by invading the bloodstream weeks or even years later. So once merozoites invade the bloodstream, they attach and penetrate erythrocytes, and the parasites then undergo asexual multiplication in the red blood cells. Here, the ring stage trophozoites mature into schizonts, which then rupture, releasing merozoites, and the erythrocytic cycle continues in this fashion. This blood stage is responsible for clinical manifestations of the disease. So that's the fever, the chills, the sweating, the paroxysms described in malaria. Some parasites differentiate into sexual gametocytes. These gametocytes then go on to be ingested during a blood meal by the mosquito. And once they're in the mosquito stomach, these microgametes penetrate the macrogametes and generate zygotes. The zygotes in turn become motile and elongated, and they're now called ookinetes. They then invade the midgut wall of the mosquito and develop into oocysts. And these oocysts then rupture, they grow, they rupture, and they release sporozoites, which make their way into the mosquito's salivary glands. And when you are bitten with an infected mosquito, the inoculation of the sporozoites then enter the human host and perpetuates the malaria life cycle. So this is the same life cycle, just highlighting the time from the inoculation. It takes about 30 to 60 minutes for the sporozoites to enter the liver and the hepatocytes. It takes about 6 or 7 days for these tissue schizonts to replicate and release merozoites into the bloodstream. And it takes about 10 to 14 days for gametocytes to form within the bone marrow. It also takes about 2 weeks for the cycle to be completed within the mosquito vector. So I think it's also important to highlight where different treatment or different drugs work. So drugs that prevent Plasmodium species invasion or proliferation in the liver have prophylactic activity. Drugs that act on the red blood cell stages are required for the treatment of the symptomatic phase of the disease. And these are such as artemisinin, lumefantrine, prophylactic treatments such as proguanil, and transmission blocking treatment or compounds that inhibit the formation of gametocytes act at this stage. So in recent years, there have been some worrying emerging potential threats to gains made in malaria control. And these can be attributed to either parasite or vector factors. So parasite-related threats include drug resistance and evasion of diagnostic detection. And vector-related threats include insecticide resistance and invasive vector species. For the rest of the talk, I'm going to focus on the first 3, antimalarial drug efficacy and resistance, parasite PFHRP2/3 gene deletions, and invasive vector species. However, just a word now on vector insecticide resistance. So insecticide-treated nets and indoor residual spraying are critical elements of malaria prevention programs. But due to exposure to sublethal doses, mosquitoes have genetically adapted, and are resistant to insecticides. Beyond this genetic adaptation, there's increasing evidence, however, of mosquitoes' behavioral changes. So the vector's attempts to reduce contact with insecticides. So biting earlier before people go to bed, spending more time resting outdoors or feeding on livestock instead of humans. And vectors with this behavioral plasticity have become more dominant than those with limited behavioral changes. And this behavioral adaptation requires investigation and more interventions, which may include interventions that target outdoor transmission, with subsequent implication for malaria control programs. But first, let's let's look at anti-malarial drug efficacy and resistance using a case to illustrate. So here we have a case which was referred to Professor Freen and us at the Parasitology Reference Lab. The patient was a young male in his 30s, an engineer who left South Africa to work on a project in the Ivory Coast. He was there for a 2-week stay and no malaria prophylaxis was taken, and he fell ill upon return to South Africa. So on the 4th of August, he was admitted to a public sector hospital in Cape Town. And at one point, there was a history of him having received inotropes in ICU for severe illness. He subsequently improved and was discharged, but more details of the admission are unknown. We don't know what treatment he received, presumably IV artesunate followed by a Coartem, according to national guidelines. However, about 3 weeks later, he became ill again with malaria, treated with Coartem. And at this point, a blood stage was sent to the NICD, requesting testing for artemisinin resistance. And we'll come to the results later. On the 2nd of October, a third admission for illness. At this time, he sought private care. He was seen by a physician in Cape Town, and laboratory results were reported as P. falciparum 0.2% parasitemia. The patient was admitted and was managed with one of the alternative regimens. Not too sure whether it was Coartem and clindamycin or quinine and clindamycin, but blood was then again sent to NICD for resistance testing. During this admission, the patient improved. He was discharged with follow-up. And at follow-up, he was well and found to have no parasites remaining on microscopy of a peripheral blood film. So as mentioned, there was sketchy history from earlier admissions. We don't know how the earlier diagnosis was made or what diagnosis was made. But what we do know and what I can share is that Côte d'Ivoire, Ivory Coast, all areas, it's a malaria endemic country. There's chloroquine drug resistance reported. And in terms of malaria species seen, 85% P. falciparum, 5 to 10% P. ovale, and P. vivax is rare. So while you're thinking about this case, let's go through some definitions that are pertinent here. So recurrent malaria is a perplexing clinical problem, and recurrence is defined as symptoms of malaria which can recur after varying symptom-free periods. And depending upon the cause, recurrence can be classified as either recrudescence, relapse, or reinfection. So recrudescence is when symptoms return after a symptom-free period. It is caused by parasites surviving in the blood as a result of inadequate or ineffective treatment. It generally applies to P. falciparum and P. malariae, but can apply to all species. And recrudescence is usually seen after 2 to 4 weeks. Relapse is the recurrence of disease after it has been apparently cured. So in malaria, true relapses are caused by reactivation of dormant liver stages or hypnozoites found in P. vivax and P. ovale. And relapse usually occurs after 3 to 6 months, although it can occur earlier. Reinfection is an infection acquired from a new mosquito bite, and this can be identified by molecular genotyping in endemic areas and applies to all species. So coming back to the case, we did do a malaria PCR, and it was P. falciparum positive only in this patient, so we ruled out a relapsing species. We did get information that he had not traveled to malarious areas between episodes, therefore this was unlikely to be reinfection. So this was the reasons for treatment failure here were recrudescence due to query inadequate or ineffective treatment. And the questions that were asked were as follows. Was he treated at the different stages with the appropriate drug? What was the dosage given and the dosing intervals and the duration of treatment? Were there any issues with absorption, such as vomiting? Was the dosage adjusted for age and weight? More importantly, the co-administration of food or fat when given with Coartem, and the patient's compliance. Was he adhering to treatment? Less concerning, but to consider is product quality. So could he have been taking treatment that was counterfeit, fake, or expired? And then lastly, where we're dealing with parasite drug resistance. So just a word on the treatment guidelines. The recommended treatment for uncomplicated malaria is artemether lumefantrine or Coartem, and the dosage regimen is 6 doses administered over a 3-day period, and the number of tablets per dose should be according to body weight, and you can see that you can find the tables in the guidelines. But adequate absorption of lumefantrine component is critically dependent on co-administration with food or drink containing at least 1.2 grams of fat. So that's about approximately 100 mils of full cream milk. So it's really essential that patients or caregivers are informed of the need to take treatment, ACT, with or immediately after a meal or with milk, particularly on the 2nd and 3rd days of treatment. Another consideration here was the patient's weight. Was he weighing more than 85 kgs? Because these patients may be at increased risk of treatment failure because there's no adequate experience or data on the use of Coartem in patients weighing more than 65 kgs. But the WHO and other agencies do recommend its use in these patients. And for patients weighing more than 85 kgs, the guidelines advise extending the treatment course to 5 days, to administering 4 tablets per dose, given twice daily for a total of 10 doses. And this is an off-label recommendation. There's also alternatives that are given in the guidelines that I won't go through if Coartem is not available or if contraindicated. Just a word on severe or complicated malaria, which he may have presented with initially. Patients should be treated promptly with IV artesunate or quinine where artesunate is not available, and in the highest level of care available. And once patients are able to tolerate oral treatment, they should be given a full 6-dose course of Coartem as per the recommendations for uncomplicated malaria. So importantly, patients who show a clinical response should show a clinical response to therapy within 24 to 48 hours. And a repeat peripheral blood smear should be performed where possible after 72 hours of treatment. For patients treated for uncomplicated malaria with an artemisinin-based combination therapy, a positive malaria blood smear 72 hours after starting antimalarials may be a predictor of subsequent treatment failure and provides a simple screening measure for artemisinin resistance or for poor adherence, which is more often the case. So in this patient, we had information, sorry, just going back, this patient, we had subsequent information. He was not over 85 kgs and there was no vomiting, but there was not enough information on the rest of the management. And so it may have been due to poor adherence. And we'll come to the parasite drug resistance testing that took place. But just a word on artemisinin. So artemisinins are established antimalarial agents with excellent safety profiles. Derivatives of artemether, artesunate, or dihydroartemisinin. And these artemisinin-based combination therapies, or ARTs, or ACTs, are recommended by the WHO as first-line treatment of uncomplicated falciparum malaria in all areas in which malaria is endemic, and this has been since 2006. So they have replaced ineffective failing treatments due to chloroquine and sulfadoxine pyrimethamine, and these ACTs have reduced the morbidity and mortality associated with malaria. Parenteral artesunate is indicated for treatment of severe malaria, And in 2010, parenteral artesunate was recommended as a first-line treatment for both pediatric and adult severe malaria after large clinical trials showed the significantly reduced mortality in patients receiving artesunate compared with those receiving quinine. So artemisinin and its derivatives act as prodrugs, and they are activated by an iron source. And how they work is cleavage of an endoperoxide ring releasing free radicals in the parasite, causing cellular damage. So parasites exposed to ACTs exhibit an accumulation of these ubiquitinated proteins, which is indicative of cellular stress. So survival of malaria parasites depends on their ability to protect themselves from the cellular damage. And how they do that is by mutations in this area where resistance has been associated with increased levels of the enzyme PFP13K in the human malaria parasite in Plasmodium falciparum. So these are not due to target modifications or efflux modulation as described for other antimalarial drugs, but rather based on an increased capacity of these PFK13 mutant parasites to manage oxidative damage. What this means is, looking at this information from a study published in the NEJM, in blue we can see against sensitive P. falciparum infection, the fast-acting and rapidly cleared artemisinins, and they are the most potent antimalarial drugs known, resulting in a 10,000-fold reduction per 48-hour asexual stage parasite cycle. In red, you can see the partially resistant strains of P. falciparum that are commonly found in the Cambodia-Thailand border. And when exposed to artemisins, the parasite load is now reduced only by a factor of 100 per cycle. So this effect is similar to that of the slower-acting drugs such as quinine. If you look at the top, another unique and advantageous feature of artemisinins is their broad range of stage specificity. But in the parasites that are partially resistant, this seems to be compromised. Here we see that parasites that are at the ring stage show reduced susceptibility, which results in delayed parasite clearance following treatment. So this delayed clearance could be a step towards high-level resistance and frank treatment failure. But so far, it's just been reported, a partial resistance has only been reported. Since artemisinins have very short half-lives, this loss of potency also renders the more slowly eliminated partner drugs, which are part of combination therapies, more vulnerable to development of resistance. So important questions that are coming up for elimination and containment efforts in the face of this is how delayed parasite clearance affects recrudescence, gametocide carriage rates, and infectivity to mosquitoes. So all of these are factors that influence the burden of disease and the potential for transmission. In terms of resistance detection and monitoring, antimalarial drug resistance can be assessed using several tools. Artemisinin partial resistance is monitored using an established list of validated and candidated Calch13 markers, so mutations in the Calch13 propeller domain of the gene, of the protein, and these are associated with delayed clearance after treatment containing artemisinin. So these mutations have emerged on the continent in Eritrea, Rwanda, and Uganda, but treatment failure rates remain low, below 10%, because the partner drugs are still effective. However, there are further studies that are needed to determine the extent of spread of these mutations and to investigate any changes to parasite clearance over time and in vitro resistance. So coming back to our case, resistance testing results at the NICD showed there were no validated or candidate molecular markers of artemisinin resistance present in both those samples. There were no novel mutations detected over this gene fragment sequence. And although there are no validated markers for lumefantrine resistance that we can test for, lumefantrine resistance has not been detected in Africa to date. So just a word that South Africa was one of the first African countries to establish a program to routinely assess drug efficacy. And the molecular testing takes place at the NICD's ARMA lab. But unfortunately, the program seems to be underutilized by the provincial malaria control programs. And samples from the South African province of Limpopo are rarely assessed by this program. So they rarely send samples, although provinces of KZN and Mpumalanga do send samples for testing. So why has the emergence of artemisinin resistance been labeled as a threat? If you look at the graph on the left-hand side, and you look at sub-Saharan Africa, the first-line treatment recommended, all of these countries use artemisinin combination therapies, including South Africa. So we know that genetic mutations are random events, but that with increased drug pressure, the more resistant parasites have a selective advantage over wild-type sensitive parasites. And looking into the past for lessons to learn in terms of the history of P. falciparum drug resistance, anti-malarial drug resistance first emerged in Southeast Asia and subsequently spread to Africa through the Indian subcontinent. So this was chloroquine resistance, which emerged simultaneously and independently in South America and Southeast Asia. And the resistant strains of the parasites arrived in the East African coast from Southeast Asia in the late 1970s, and then spread relentlessly across the continent over the next decade. Resistance to sulfadoxine pyrimethamine, which was the immediate replacement of chloroquine, rapidly emerged in Southeast Asia in less than 5 years of usage. So how this translated into the South African context is, as you can see here, this is data from 1980 to 2020 from the 3 endemic provinces in South Africa, looking at the total number of confirmed malaria cases. And this is just to highlight the drug resistance and insecticide resistance malaria outbreak that was experienced in 1999-2000 malaria season. Here, KZN bore the brunt of this malaria outbreak, reporting in excess of 40,000 cases and over 300 deaths in 2000. And drivers of this outbreak included the establishment of these sulfadoxine pyrimethamine resistant P. falciparum parasites, as well as the emergence of pyrethroid resistant Anopheles phanestes vector populations. So this just goes to highlight the effectiveness, and then more importantly, subsequent to the outbreak, there was implementation of an artemisinin-based combination therapy in KZN, and this was the first in Africa. There was also reintroduction of DDT-based indoor residual spraying in the province, and these sustained implementation of these interventions did drive down the case numbers. So this highlights the effectiveness of ACTs and insecticides used for vector control, but that this needs to be regularly assessed. I've put in a malaria threat map from the World Health Organization to highlight where molecular markers of artemisinin resistance has been detected. And what you can see here is that in the same region where chloroquine and SP resistance emerge, which is in Southeast Asia, and you can see the dark blue dots and the high percentage of studies detecting molecular markers of resistance in this area. So resistance has now emerged against artemisinin in these areas. And the concurrent evolution of resistance against partner drugs alongside the reported artemisinin resistance is extremely concerning. I want to point out that there's also lots of studies and detection of molecular markers of artemisinin resistance in Africa, but the data is lacking from several other countries. And with no alternative drugs likely to become available soon, it is essential to preserve the therapeutic lifespan of ACTs. I've included this in because this gives us data from Africa, and this review looks at the frequencies of the Calch13 artemisinin resistance mutations in studies from Africa, and it highlights that only 4 African countries have reported 6 validated artemisinin resistance associated mutations. But although these have been identified at low frequencies in Ghana, you can see in Rwanda, in Uganda, and in Tanzania, these still signal, they're an early warning signal for Africa because a rise in frequency and spread to other countries would be catastrophic for malaria control. So we're beginning to see the past repeat itself with this. And just to importantly emphasize, these were de novo emergence of ART resistance markers in Africa. And it is a concern because obviously as it emerges, millions of lives are potentially at risk. So I'm just quickly going to highlight in this slide that response to anti-malarial drug resistance has taken on multiple different forms, but there are several next generation medicines in different trial phases, but there is no effective alternative to artemisinin to date. And one of the strategies is looking at working on triple ACT to try and counter artemisinin delay, partial resistance. So moving on to parasite PFHRP23 gene deletions. Microscopy is the gold standard or historic gold standard for confirmation of malaria, but it's frequently delayed and may be inaccurate. So the rapid diagnostic test lateral flow assays have been used with increasing frequency, especially in Africa, with improved diagnosis, more rapid turnaround times, allowing for more rational use of anti-malarial drugs. And they actually have transformed malaria control and improved surveillance in Africa. So globally, 2.7 billion RDTs for malaria were sold between 2010 and 2019, and the majority were distributed in sub-Saharan Africa to diagnose P. falciparum infections, targeting one of the antigens, the histidine-rich protein 2. And as you can see here, these are examples of thick and thin smears for microscopy, and there are multiple different RDTs for P. falciparum on the market, and the target for the antigen, or the antigen target, is HRP2. So HRP2 amongst the most abundant malaria proteins, and they're produced across the asexual cycle. And these RDTs are based on this because they show high sensitivity. And parasites that cannot express HRP2 may not be detectable by RDTs based on this. And those that are no longer able to express both HRP2 and 3 are completely undetectable by such RDTs. So the inability of first-line testing to detect infections with P. falciparum will put patients at risk of misdiagnosis and significant morbidity and potentially death. In certain areas, HRP2 along with pan-LDH, so that's lactate dehydrogenase combination tests, are used. So the HRP2 is P. falciparum specific, and the LDH is pan-malarial antigen, so detected across all species. So as you can see here, in HRP2 deletions, you may have an infection with Plasmodium falciparum that does not show up on the lateral flow assay, but the lactase dehydrogenase will show up, and this may be incorrectly interpreted as a non-falciparum infection. In either state, both these situations, it will lead to delayed or misdiagnosis or non-diagnosis of the patient with subsequent potential life-threatening consequences. And routine surveillance estimates of malaria incidence will be adversely affected if this becomes widely spread. Here again, we have a malaria threat map showing where all of these HRP2 gene deletions have been detected. They were originally first reported a decade ago in Peru and were subsequently found in neighboring countries. And this led to a reversion to microscopy as the primary diagnostic tools in this region. And over the past 6 years, there have been an increasing number of African and Asian countries where diagnosis is heavily reliant on these assays, which have reported deletions, HRP23 deletions, raising the threat to a new level, such that WHO has recommended that countries with reports of these deletions and their neighboring countries conduct representative baseline surveys to determine the prevalence of these deletions, causing false negative RDT results. And that if you reach a threshold of more than 5% of these deletions, there requires a change in the RDT that's being used. So there have been multiple publications, and as you can see here, deletions have been detected on the African continent. In South Africa, this surveillance is not formalized, but to date in the studies that have been done by ARMA, none of these deletions have been detected. We also get many referrals here at the Parasitology Reference Lab from NHLS labs, usually due to discordant or discrepant RDT microscopy results. And we've had no cases where we considered testing for these gene deletions. I've included this table because I think it's just to drive home the fact that although these gene deletions are emerging, in most settings, a reason for a false negative is not due to deletions of the HRP2 or 3 genes, but rather due to other reasons that need further investigations. And the most common reason is usually down to operator-dependent factors or operator error in performing of the test. There are other considerations, and you can look this up. This is from the WHO information note on false negative RDTs, which look at the use of an imperfect gold standard as a comparator, product quality or design, the conditions under which these RDTs are transported or stored, and host parasite density. But I just want to point out that if you are thinking about HRP2/3 gene deletions, the parasite factors, what the recommendation is that patient samples which are negative on an HRP2 test line of at least 2 quality assured malaria tests and positive on the PAN or PFP LDH test line when a combination RDT is used, and that the sample is confirmed to be positive microscopically for P. falciparum by 2 qualified microscopists. If this is the case and these conditions are met, then those samples do need to be further investigated for gene analysis for these gene deletions. I've put this in just to highlight some examples demonstrating operator-dependent reasons for false negative tests. So things like too much blood, which clog the well and cloud the result window, may result in a false positive. In the middle, we see a series of tests where the blood and the buffer were not applied correctly, so they are both applied to the buffer well. This results in reduced efficiency in lysing blood cells and binding to the free malaria antibodies, resulting in a false negative test. Reading at an incorrect time, too early or too late, also increases the chances of an incorrect result. And using incorrect amount of buffer, so if using too much buffer, will dilute the blood sample, resulting in a false negative test. So by far and large, most of the reasons for a false negative RDT is usually due to, in our setting, due to operator error. So in terms of response to diagnostic tests, the spread of these gene deletions presents a major threat to reliable diagnosis, and it does call for a diversified diagnostic landscape to address this. There are current products in the R&D pipeline to address these gaps, especially focusing on improving existing point-of-care platforms and also developing alternatives using a range of sample types and different technologies, including artificial intelligence. So I'm coming through to invasive vector species. So invasion by vectors that are adapted to breeding in urban environments, such as the recent spread of Anopheles stevensii in the African region, may be putting urban populations at increased risk. So this vector was native to South Asia, but it has been expanding its range over the past decade, with detections reported across these African countries, most recently in Nigeria in 2020. So where it's been reported in the African region, it has been found to be resistant to many of the insecticides used in public health. And the invasion into sub-Saharan Africa, where the burden of malaria, as we've seen, is highest, and now where over 40% of the population live in urban environments, has raised concern because this vector seems to be adapted to the urban environment. It differs from malaria African vectors, which are typically found in rural areas. It has a lot of characteristics that make it difficult to control. It likes being near humans. It can lay eggs in any available water source, such as water containers, abandoned tires, and flower pots. Eggs can survive being in dry conditions for a long period of time. It can feed on host both indoors and outdoors. And it obviously has reduced sensitivity to insecticides. So the invasion of this species has been quite troublesome. And it has been thought to have driven resurgence of malaria in Djibouti city and to be the source of at least one outbreak in Ethiopia. So in September 2022, a new initiative was launched aimed at stopping the further spread of this vector on the African continent, and to determine whether it can be eliminated from areas that have already been invaded. So just an update, this species has not yet been detected in Southern Africa, but the South African National Malaria Control Program, with the support of the NICD, is increasing surveillance activities in areas where the species may occur, such as more urban areas, and encouraging communities to reduce potential breeding sites, such as using more appropriate methods for storing water. History has taught that lessons can be learned from previous invasive vectors. In the 1930s, Anopheles gambiae invaded Brazil, and with much effort was completely eradicated eventually, and hailed as one of the big success stories in pre-World War II public health. But eradicating Anopheles stevensii from Africa will be difficult and expensive, and this is an emerging infectious disease disaster that can still be prevented with concerted effort. Again, the World Health Organization has vector occurrence of Anopheles stevensii, and you can see originally native to Southeast Asia now has invaded across into Africa, specifically in countries in the Horn of Africa. And this was an interesting paper, and this is something from one of the researchers working in the Horn of Africa, where he says something new and insidious has arrived. The new mosquito arrives at a bad time in the fight against malaria. Africa's native mosquitoes, that's Anopheles gambiae, have become increasingly resistant to insecticides, and Anopheles stevensii is already resistant. In addition, the malaria parasite is getting not only tougher to kill, but tougher to spot. Malaria strains that don't show up on rapid diagnostic tests are becoming more common. We don't want the three to meet: the drug resistance, the diagnostic resistance, and the highly efficient vector, he says. And if asked what happens if they coexist, we don't know. It's really dangerous. You can't detect the parasite, you can't kill it with a drug, and the mosquito is now wise enough to evade control mechanisms. So given all of this, there is a glimmer of hope, and I'm going to finish shortly. So with vaccines, a successful malaria vaccine has the potential to reduce global disease burden, and a leap forward in advancement of the fight against malaria. The World Health Organization has approved 2 vaccines for the prevention of malaria: the RTS-S01 vaccine, or Mosquirix, and the R21 Matrix M vaccine. And this is for children living in areas of high transmission. The first vaccine was recommended in October 2021, based on pilot studies done in children in Ghana, Kenya, and Malawi. And the R21 vaccine recommended in October 2023. Both these vaccines have not been tested in a head-to-head trial, but both prevent around 75% of malaria episodes when given seasonally, and seem to prevent cause a substantial reduction in severe malaria hospitalization and a drop in child deaths. There's no current evidence to date showing one vaccine performs better than the other, and the WHO says the choice of product to be used in a country should be based on programmatic characteristics, vaccine supply, and vaccine affordability. However, there are some caveats to this. These vaccines require at least 3 doses and a 4th booster dose, so making rollout in vaccine control programs quite difficult. There also needs to be scaling up of vaccine availability, but there are efforts to try and address these problems. Ideally, what you would want is a vaccine that can successfully, or development of a vaccine that is effective in older children and adults, which requires only 1 dose and is effective against all human malarias. These vaccines target the sporozoite stage of Plasmodium falciparum only. So just to end with some take-home messages, malaria season has started in South Africa. Beware that cases generally peak in South Africa in January and February after the holiday season. There should be a high index of suspicion for malaria in patients with fever or flu-like illness that occurs up to 3 weeks after potential exposure. particularly if patients have traveled to or are resident in the malaria endemic area. Think about Odyssean malaria in people who have had no recent travel history. Malaria should be considered as a differential diagnosis and tested for in patients with unexplained fever who get progressively sicker, especially if they have low platelet counts. Just remember that COATM remains very effective in our context for the treatment of uncomplicated malaria. Patients must take each dose with some fatty foods such as milk, cheese, or peanut butter to ensure optimal absorption of the drugs. IV artesunate is a recommended treatment for severe malaria and has significantly better outcomes compared to IV quinine, is easier to use, and is a preferred treatment. Just a word for relapsing malaria, although not often seen in our context. For P. vivax and P. ovale, follow-on treatment course of primaquine is essential to eradicate the residual hepatic phase to prevent relapse. So just to be aware of emerging anti-malarial resistance or partial resistance to artemisinin, and that recrudescence and treatment failure in our context is usually due to the other reasons as we have discussed. Be aware of the evasion of detection using the HRP2-based RDTs, but also note that false negative RDT results are most often due to other reasons, most commonly operator error. If you have any queries around these kinds of scenarios, contact us at the NICD to discuss cases and molecular testing if suspected. And just to end on a reminder that malaria is a Category 1 notifiable medical condition and that it does require immediate reporting via the NMC platform. So to end, I'd like to thank the malaria activities within NICD are shared by multiple different divisions within CZPD. And I'd like to thank Parasitology Lab, Anti-Malarial Resistance Monitoring Lab, especially Dr. J. Sriraman, and the Vector Control Laboratory, especially Prof. Basil Brook, who are all engaged in malaria control and supporting malaria activities. And then obviously a special thanks to Prof. Freen and Prof. Bloomberg, who are always around to give expert advice and guidance. And with that, I will end and happy to take any further questions. Thanks.
Great. Thank you so much, Charlotte. We're a little bit over time, but it's a really important topic. So I'm very happy to take some questions just to round things off. I'm just looking through the chat. So, I mean, I guess maybe a good place to start. So in terms of the let's say, low-grade treatment resistance to artemisinin-based therapies, I guess what we could do as clinicians is make sure that we do that smear at 72 hours, right? And then if it's positive, look for reasons, understanding that the vast majority will not be due to this particular, this particular resistance mutations, but rather other causes, but at least we'll detect any if they do become more prevalent. I mean, would you say that's, I mean, it's in the guidelines already, but I know it's not very well done by clinicians.
Correct, and that's an excellent, point to start. Like you said, repeated smears are recommended, but they don't seem to be well done. And I think in this emerging context, they do need to that guidance needs to be followed. Obviously, you need to think about it if the patient is not responding, because patients should respond within 24 to 48 hours of treatment. But it's just to have an awareness that most of these cases will be due to other issues as highlighted, but to keep in the back of your mind, yes, consulting and possibly discussions around testing for partial resistance to artemisinin. Artemisinin do need to now form part of that differential diagnosis.
And then Eunice Moose has got a good question about the particular mutation that gives you a false negative on the rapid test. Does that alter virulence in any way, or are they just as virulent as the normal? They're just harder to detect. I mean, it may be difficult, I guess, to tell the two apart given delayed diagnoses. Yeah,
and I think it's a good question. So it speaks to fitness cost, and these HRP2, this area apparently helps detoxify heme in the parasite. But apparently from studies that have been done, apparently these deletions do confer fitness cost to the parasite, but like with other things and with other mutations, there may be compensatory mechanisms. So there have been some recent articles and reviews around this, and they do seem to confer fitness cost to the parasite.
Interesting, thank you. Just last question is just asked about there's a comment in the chat about the treatment of malaria in pregnancy. That's the same pretty much as without pregnancy, right? The prophylaxis may be different, but treatment the same.
Yeah, correct. And I think the most of the queries that we get around pregnancy, I mean, obviously, it's very important to identify and to diagnose malaria in pregnancy because of a severe illness that can occur. And we do get asked questions about prophylaxis and travel to malaria endemic areas in patients who are pregnant. And at present, there is no viable chemoprophylaxis available for patients who are pregnant. So the recommendation is not to travel unless absolutely imperative to travel to a malaria endemic area. And I know Prof. Freen is on the call, so he may be able to add in a few, he may be able to add into that.
Yeah, sure. John?
Oh, yes, that's Charlotte's quite correct. That there is no suitable prophylaxis for pregnant women or for young children, for that matter. And if travel is absolutely necessary, they must take all possible precautions against mosquito bites, which goes a long way to preventing malaria, as long as it's done properly and people understand that mosquitoes can also bite outside. They like biting around the ankles, so putting on long pants and covering up skin as far as possible, and putting a repellent on are all important steps towards preventing mosquito bites and therefore preventing malaria.
Yeah, and I see in the chat some worrying things. I don't know, Therese DeVray is one of our travel medicine experts, and I see both Therese and Tina have written about a worrying trend where pharmacists are diluting or cutting the coartem tablets. Well, sorry, beg your pardon, the Malinol tablets again for children. I don't know, Therese, if you want to mention anything verbally.
Thanks, Jeremy. It's just that, people are desperate to get prophylaxis. I mean, they're going to Mozambique, they're going to Kruger, and you can't just tell them there's nothing to take. I mean, yes, it's prevention not to be bitten, but chemoprophylaxis is really in a high-risk season, really so important. But that's why we're hoping we're going to get some mefloquine in, because that's WHO standard for pregnant women and children under 5. But we're just so worried, and we think it's appalling that that we got to the stage where we don't have malaria prophylaxis for such a huge part of our population, especially with the rising numbers. So we're very concerned. Sorry about that.
No,
just to add to that, Jeremy, it's not possible to safely divide tablets, as Therese points out. That really can't be advised.
Yeah, no, thanks, John. Thanks. Yeah, so sorry, yeah, and as you point out, Therese did put that in the chat as well, and Tina. But as you said, I think the issue is people have no other option. But I mean, as you rightly said, that shouldn't be assumed to be an option necessarily, given that it's pharmacologically ill-advised. Really worrying though to be at this position. Okay. But thank you. I think we have to end it there. But thank you very, very much to Charlotte and to John and to others who contributed. But to Charlotte, thank you so much for going through really some interesting topics and really the sort of the latest in malaria and some worrying things. Malaria is always a sneaky customer, so some worrying things, but good to know that we have